Welcome to today's webinar. The topic for today is successful contracture management. My name is Megan Klein and I will be hosting today's webinar. Please note, the information contained in this presentation is intended to provide general information and not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today's webinar will be presented by Karen Bonn. Mrs. Bonn founded and incorporated Restorative Medical Incorporated in January of 1992. Formerly a director of nursing in long-term care facilities, she became frustrated that persons in nursing homes commonly develop life-altering physical deformities like fetal position. Over the 25 years of RMI, she developed and manufactured flex technology, splints, under brand names like NeuroFlex, Safe, Restair, and Restorative, and Bendees. As the clinical specialist for Restorative Medical, she routinely did restorative patient consultations, spoke about restorative patients to state, national, and international audiences, including as guest lecturer at Beijing University, to the physical medicine and rehab residents at the Tbilisi Medical School in the Republic of Georgia, and as a guest lecturer to the Canadian Conference of Hand Therapists. She has also presented to various clinical audiences in Scotland, Ireland, England, and Australia. She is a registered nurse and a certified orthotic fitter. She authored the DON's The Corner for Long-Term Care Management magazine from 1995 until 1999. She has served on the Region D. DMERC Advisory Committee, DAC, Membership and Products Committees for the National Association for the Support of Long-Term Care, the NASL, and is past president of the National Association for the Enhancement of Patient Care. She is a member of the American Holistic Nurses Association, provides consultations with GLG, and serves on the Kentucky District Export Council that works closely with the United States Department of Commerce's Commercial Service. Bonn has been nominated for Businesswoman of the Year by the Kentucky Association of Manufacturers. Ms. Bonn, a widow, resides in Brandenburg, Kentucky, where she enjoys being a mother and grandmother, playing golf, and is active in her church work. She looks forward to writing and doing consulting work. And now, please welcome Karen Bonn.
Thank you all for being with us today. My name is Karen Bonn, and as of October 31st, I have retired. So I do look forward to playing more golf, but I do enjoy consulting and speaking, so I look forward to those things also. Today we're going to talk about successful contracture management. Excuse me. And to me, restorative patients are like a puzzle, and it's your job to solve that puzzle. And everyone, they'll have similarities, but everybody is unique. So we want to look for those different opportunities that their specific condition provides to us. I'll just briefly mention serial casting because I don't personally know of any skilled facilities where the therapists do serial casting anymore, but it is still done in some rehab facilities and hospitals and more, I think, with children, with younger patients. But if you are doing serial casting, just think about it's labor intensive. You have to have one or two people at least to hold the patient's extremity while you're casting. You have to change the cast every time you want a different degree. Typically, they aren't real good at allowing airflow, like inside the elbow and knee, where Restorative Medical Flex technology certainly does. You can remove them to bathe. All you have to do is readjust two knobs, and you've taken it from one degree to another. So it's a wonderful alternative to serial casting. And one of the things we've always tried to do with restorative medical is provide you the appropriate tools for this type of patient. It's hard for you to do your job if you don't have the right tools. I categorize lost range of motion into 3 different types. One would be simple adaptive tissue shortening, 2, abnormal muscle tone, and 3, by far the most common, is a combination of both. Short adaptive tissue, it could be you have a patient depressed, they're a couch potato, they're short of breath, their heart is not very good, and then they're just weak. And during the whole COVID, we have found that while people are quarantined in their rooms, they spend the whole day in bed or in a chair. So they're lacking not just physical, but mental stimulation. And when we're finally getting back into them and we're kind of trying to regain some normalcy, we have found that these patients have developed so many contractures. So our company, like I'm sure others, is being hit hard by devices because we've got to treat these patients. Dehydration may certainly play a role, and when you know you're going to pick someone up on caseload or in restorative or at home, and encourage the caregivers, nursing or the caregivers, to increase that fluid intake, because a nice moist muscle is much easier to work with than one that is dry. We typically don't have collagens or scar tissue to break through, and what is required to treat short and adaptive tissue is prolonged low-load passive stretch over a long period of time. With this adaptive tissue, re-lengthening, remember, we do not re-stretch. We stretch to re-lengthen. That's huge. That is a huge difference, and this requires a process. We've known, well, this was written in 1984, that prolonged stretch is what is a good treatment protocol for these patients. Here is a diagram of a contracted and relaxed muscle. Now, we know that literature says it requires about probably at least 6 weeks of prolonged low-load passive stretch to realign the proteins in the muscle to prepare it to be re-lengthened. Well, these proteins, if you look at the bottom left, are actin and myosin, and this is a relaxed sarcomere. The proteins are in units called sarcomeres. If you look to the right, it's a contracted sarcomere. Now, this is normal, healthy muscle tissue, and you contract and relax as you move about your normal activities of daily living. Problem is, if you get stuck over here where it's contract and the sarcomeres or units are all going to mash together, and this is what causes lost range of motion and physical deformity. Here is just a little more anatomically friendly picture of actin and myosin. You can see bottom right, and this is in a sarcomere unit. Abnormal muscle tone, and I'll refer to it the rest of the presentation as tone. That's what the buzzword is commonly in clinical areas. Excuse me. But it may result from a disease process. Let's say you have Parkinson's. A lesion, you have a benign or a malignant brain tumor or central nervous system. You could have an injury, which would be to the brain or spinal cord. And whatever adversely affects nerve conduction, it could be lack of oxygen, anoxia to the brain. It could be fluid buildup. Excuse me. I took this from eMedicine from Medscape, and it does a nice job, I think, of describing this either intermittent or continuous tone. May present as if the muscle is stiff, or tightness. People may say, my muscle's tight. Again, it's caused by disease or damage to a portion of the brain or spinal cord that controls voluntary movement. May occur in association with, and these are many of the diagnoses that you treat every day, and that's spinal cord injury, traumatic brain injury, multiple sclerosis, cerebral palsy. Again, a lack of oxygen. That's a big one to cause contractures. Their tone can just be amazing. And the metabolic diseases. If it impairs your balance, then what's it going to do? It's going to make your patients more prone to falls and to injuries. It affects their endurance, their transfers. You're transferring this patient from bed to chair, and they have an episode of tone, and they can fall out of your arms, and they can flail, they can harm themselves. So it's very important that we try to get a handle on this. It can certainly affect their sleep cycles, and you wonder how many people in long-term care or at home get adequate REM sleep. And this is important for everything about them. It affects their therapy. It affects their dementia status. So it's very important that we do everything we can to help them to get good quality sleep. It can certainly cause pressure or ulcers from bony prominences and also from shearing from the movement of muscle tone and spasticity. And it certainly can contribute to pain. Hypertonia is uncontrollable muscle spasms, stiffening or straightening out, and this can be inward or it can also be to extend out. So someone may, if they have an episode of tone, they may actually reach out like they're hitting you, but it's nothing they can control. And to improve muscle function, to protect against the postural asymmetries, the use of supportive and protective devices may be necessary. So there's plenty of evidence out there that you can't treat, in my realm, I will say, I've never seen a patient with tone that you could successfully treat without some type of device, because you can stretch all you want to and work with them Monday through Friday, Saturday morning, and certainly Monday morning you go back in and they're where they were or they've gotten worse. So we have to have a device to work on it and to maintain our gains. This is one of the first Kentucky collars. You can see it was, all of them were custom made years ago. And today they're made in sizes from actually a doll size all the way up to the largest adults. Excuse me. This lady had torticollis from a whiplash injury. So we take these very, very seriously. And when people call, or their therapists or their other clinicians or their family members call and say, I have cervical dystonia, or I have whiplash, or I have torticollis, and I'll try to ask them, did you ever have an injury or a fall? And if you root back through, get them to thinking they'd never thought about it, but maybe 2 years ago they had a car accident, or they fell, or something happened and they had a whiplash injury, whether they knew it or not, but many of them knew. And this can result in torticollis or cervical dystonia at a later time. So we knew that this lady had no shortened tissue, because she said when she laid down on her back, her neck would be relaxed, like when she woke up in the morning. When she sat up, her head would go lateral, just to the side. But when she stood up or got upset, she would get this wry neck or twisting, which is torticollis. So I put the Kentucky collar on her, and I said, I can't promise you anything, but I hope this will relax. And I'm always timing, because usually it's right around 15 minutes that you will see after you put one of these flex technology splints on, that you'll see a relaxation. So her whole neck is all twisted, and she's just talking and talking and talking. And at 10 minutes, she said, I feel funny. Well, I'm thinking, oh, goodness, are you all right? And she said, no, I felt funny. And but then she went on talking, and at exactly 15 minutes, her head came to neutral. I mean, it was just so cool. And she really didn't even realize it. I asked her, and then she did this beautiful smile. And if you remember, when she stood up is when her right neck kicked in. So I had her to stand up, and it remained relaxed. This one, I love this lady's story. A therapist sent me these pictures a couple of years ago, but it's such a good case to teach, to present. If you will look at her in the first slide that she actually has on the vertebrae TLSO, that you're going to see it later in the product demonstration. But her right hip, her hip is up. Her right shoulder is up. You can see on the other side in the middle of her body, she's going out. So she definitely has spinal curvature. She's post-CVA. She's had a stroke. She'd had a stroke previously, was able to live at home, but she had another stroke, and she's in short-term rehab, Part A rehab here, and they have just told her she won't be able to go home. She's going to have to remain in long-term care. So the therapist found her vertebrae, put it on her. Now I want you to look at the angle of her shoulder and the distance between her ear and her shoulder. Now in the middle picture, they have added the Safe Serve headpiece. It just slides down into the back, and it's adjustable because we want to do everything gradual. That's one of the keys to our great success. We want the body to do, we allow and work with the body to go through its own natural responses and do its own thing. We don't try to push against it, because that just puts us back past ground zero. All right, less than 15 minutes. Every one of these pictures that you'll see in this presentation are within 30 minutes after their first initial fitting. I want you to look at her hip has gone down. Look at her shoulder has gone down, and the distance between her ear and her shoulder. In the first one, it was laying on her shoulder. And this is common. If you haven't seen it, you will, because it's very common. But here, the exciting thing was that therapy had her on caseload for about 2 more weeks, and she was able to go home and live with her daughter. So that's one of those success stories that you love. Okay, we're going to talk about 2 organelles, muscle spindle and Golgi tendon organ. And we're just going to talk briefly. We'll touch on it, but I want you to know what makes up the neurophysiology for abnormal tone and spasticity at the site. These are wonderful mechanisms when you're healthy. Keep in mind, it's when you have some assault on your central nervous system that you really have to zone in on these and remember what they do, because you've got to work with them and not try to push against them. But it's a sensory organ that receives information from the muscle. And if you're reaching out to get something, that a muscle spindle says, it realizes and monitors how fast you're reaching out and how far. So when it thinks you're going too far and you're going to damage something, then it sends a reflex arc signal to your spinal column and relaxes. So if you're stretching too far too fast, it's going to stop that or slow you down. The Golgi tendon organ is right at the base. If you see the illustration above, you'll see it, the muscle and then the bone and the tendon, and it's right there in the tendon. And it's also a sensory organ, but it receives information from the tendon, and it senses tension. So if you're, and I've got another illustration that's great, but if you, let's say you're lifting weights and it's too heavy and your body doesn't want you to damage again and maybe pull the muscle away from the tendon or strip the tendon away from the bone. So it will inhibit the muscle with the reflex arc, therefore protecting you from injuring yourself. And here's, I don't know if you're familiar with Benjamin Cummings. I'm a fan. He's quite well known for writing biology textbooks on the university level. And this, to me, this illustration just really sums up our flex technology. And that is, you have a load, you have weight on the hand, and you're trying to keep that arm flexed at the elbow. Eventually, the weight tells the Golgi tendon organ, it's just a little stretch, a little flexible stretch, because this is not rigid, right? So it inhibits the interneuron in the spinal column and relaxes the muscle. It inhibits the muscle from being able to contract. And then you relax and the load is dropped. And that's exactly what you see with our flexed elbow. And of course, the knee would also be hinged. Low tone also needs to be splinted to prevent deformity, for comfort. So the extremity is not just hanging. Your extremity will appear floppy. The muscles are just not being innervated, and you see this with strokes. So if your arm is hanging down and it's flaccid, you want to support it because the weight of that arm tends to pull the arm out of the shoulder socket. And once you've overstretched all that in there, then it's so hard to get it back, and you may never. So you want to support the arm. Hands are a big one that you see that are flaccid. So let's put a nice low profile, comfortable hand splint on them to maintain the shape of that. Certain number of these people are going to develop tone over time. So you've already, gotten kind of ahead of the game there. This is little Vance, and he was 2 here. He had low tone on his upper body. He wasn't really a floppy baby, but he was flaccid. But he had tone basically from the waist down. His little knees were contractured about 30 degrees, and they came out just really good with our little knee splints. But his speech therapist was trying to do E-stim with him for swallow, because he tended to aspirate, and she asked for something to help with his upper body posture. So we just did a little TLSO, and you can see the opening for his peg tube. So for quality of life, the family needs to be able to take these babies and go and do things. So mom and dad could take him with them. When it was time to feed him, they could pull his little shirt up, connect his feeding. When it was finished, just disconnect, tuck his shirt back down, and they were good to go. So this is the little TLSO, hold his shoulders up, and he loved Mickey Mouse, but he couldn't watch it before because his body would just flop around. And that with the cervical extension was just wonderful. This is Vance today at 14. Vance has laid on a pallet for so long that you can see what gravity has done. And that muscle memory is pulling his little arm back. It's hard to even see on the top left what is arm, but here you can see why the design of that wheelchair apparatus. I have no idea. I think it's apparent there were no therapists involved in that, but maybe to keep his hand from going farther back. But he has muscle memory of his arms going back like that. You used to see that a lot in NICUs when the babies laid like that, and they had problems then unless it was corrected down the line. So we want to bring Vance back. So he has on here restorative hands and flex elbows. And we're going to hold his hands across his chest for periods of time because his shoulders and his arms have to develop new muscle memory. The muscles in the back of the arms are shortened, and the ones in front have lengthened and across his chest. So we're going to have to make them realize that they need to be in a shortened position in the front and elongated in the back to allow him range of motion. Why? Rigid static splits may be contraindicated for patients with abnormal muscle tone. They may not provide prolonged low load passive stretch. If they do not allow the muscle to shorten during muscle spindle firing, that causes a contraction, it may create the risk of contributing to an episode. So we have found that it's much more therapeutic to allow the patient to flex into, the device flexes with them, but provides tension and takes them back to the preset degree. Ken Mook was a PhD MD, chief of brain injury at Fraser Rehab in Louisville, and I learned a lot from him. And one day I just said, Dr. Mook, would you write me a statement that talks about abnormal tone and spasticity that I can use? And he wrote that, and you can read it. But he said he's found that a static rigid splint is not effective in controlling spasticity because it provides a persistent of a spastic event by not allowing the muscle to shorten. A splint that has static properties with dynamic give, that's a Kentucky term for you who are in Kentucky, a spastic event allows the muscle to shorten, thereby the spastic event regresses, and yet the splint maintains proper positioning of the joint. Flex technology. It relaxes the increased tone and spasticity. And I wanted it purely clinical, but he also wrote that Neuroflex restorative braces made by Restorative Medical are the best I've seen and used, and I wholeheartedly recommend this company's products for bracing of limbs with spasticity. So he wrote it for me, so I used it. Okay, the third is abnormal muscle tone with adaptive tissue shortening, and this is, of course, by far the most common. And this is the one that used to especially be I won't say diagnosed, but mislabeled maybe as a fixed contracture. We used to hear that, 20, almost 30 years ago when I started doing this. You heard that so much, and back when I was a DON. And we know now that so much of that is rigidity. It is tone. And after the tone is worked through, you can determine if there's underlying shortened tissue. And there certainly may be. Sometimes these patients, if you can relax them, get them good and relaxed, they don't have any shortened tissue at all. But a lot of them do if they've had tone for very long, and some of them have gross deformities. And we're realistic. I'm not going to tell you you're going to totally correct every contracture out there, but this is a slow process. And in my ideal world, I'm totally aware that you have to bill your therapy. If you're a therapist, you have to be able to bill that. So you have to follow Medicare guidelines or whatever insurance company is dictating your therapy regimen. You also have to abide by your company's productivity schedules. But I'll tell you, in my ideal world, we would pick these patients up and we would set the device just to work through tone. All we want to do, we want that muscle and the nervous system to be, just get used to working through tone and reaching relaxation. When you're comfortable with the wearing schedule and all, discharge them back to nursing, but put on your calendar, you're going to pick them back up or at least look at them in about 2 months. And you educate nursing to tell you when the splint has gotten too loose or if it has. So pick them back up and then readjust the splint. Keep them on caseload for a couple of days, whatever you can justify and feel you need. Then discharge them back to nursing. If you do this every 2 months during the year, we have no idea where at the end of a year's time or 2 years' time, where they may be. So it's not like orthopedic, you pick a patient up and you talk about days and weeks, typically. With restorative patients, you're going to start out talking months and years because they didn't get here overnight. There's underlying factors. It's not like you sprained your wrist or you had knee surgery. These are patients who are going to most likely need us in some form or fashion for the rest of their lives. If a patient goes to the hospital and you're afraid to send their brace because you know you won't get it back, it got damaged, destroyed, whatever reason, then they may decline. They had the flu. They had something, COVID. If they do, reduce the degree of extension to where it's appropriate and then gradually restart the process. Hopefully they'll make progress a little quicker than they did in the first place, but if not, you know how to do it, you just do it. The stretch reflex, again, is part of that whole good thing to protect you, but it can kind of come back to bite with these patients. So, if you're stretching too far too fast, the muscle spindles trigger this stretch reflex that's going to stop you from going too far too fast. It's just basically putting on the brakes. And there are two components to that, a dynamic and a static. And since yesterday was the birthday of the United States Marine Corps, we're going to say the Marine Corps are the dynamic component. My son-in-law happens to have just retired from the Marine Corps, and we're very proud of all our men and women in service. But let's say you've got a hot spot somewhere in the world, and the Marines come in and they take over the area and they root out the bad guys. Then the static would be the Army gets there, they're bigger, they come in and they stay in the area as long as they need to make sure everything's okay. So this is what you see when you have a dynamic. It can be knife-like. Let's say you're stretching someone's elbow and you go a little bit too far or a little bit too fast, and it rebounds back so quickly, knife-like. They can hit themselves. They might hit you if you're in the way. It's nothing they can control. And I don't know about you, but I think back and I did that to people before I realized what I was doing. I thought I was doing the right thing. They needed to be stretched. Thank goodness I've learned. But the static then is it will remain in that flex position, or it can. I've had alert-oriented residents tell me that it could last. It's like a Charlie horse that lasts 2 to 6 hours. So it can be torturous. So that's the static. Okay, you can read that. I'm going to move on. This is holistic. And if you think about it, the first time I did this diagram was in front of the SADMERG years and years ago, and they're the agency that decides what all the billing codes are and how much they pay and all that. So I have redone it and kind of spruced it up over the years, but lost range of motion contributes to, and if you'll see the color of the arrows going back and forth, it's how that one affects that and that affects that. So if you look at nutrition, if you can't sit up and swallow correctly and get in enough food, then you're going to lack nutrition. Down under that is skin tissue and wounds. Nutrition, definitely, you can't heal a wound if you don't have good nutrition and hydration. Hygiene, when those knees are stuck together, it's very hard to do proper pericare under the elbow, even brush someone's teeth. Over here, circulation, it's hard with contracted joints to get blood to circulate through them. Breathing, if you're all over, your head's in your lap, it's hard for your lungs to bring in enough oxygen to send it to all the parts of the body. So that goes back over to skin tissue and wounds. Elimination, it's hard to fully empty your bladder if you're laying back and not reclined. You need to be at least in a 90-degree position. For ladies, maybe a little forward. Men ideally need to stand to fully empty. And then, of course, you always have bowel problems in long-term care. Orientation, if you can't hold your head up and view your environment to receive stimulation from that environment, it's going to be really hard to stay oriented. And again, I think of all these patients that have been quarantined with COVID. And the bottom one is, to me, the very most important one is you can have some health, but if you don't have dignity and feel self-esteem, then you may be depressed, and that affects everything. It all goes downhill. So these are the things we want to look at, and when we do our care plans and our assessments, we need to think of all these features and be very holistic in our treatment plans. Psychosocial, again, interaction with others, lack of environmental stimuli, decreased feelings of self-esteem, feelings of helplessness. These people, maybe mothers or fathers or priests or business people or teachers or rocket scientists, but now they're not of help to other people. They're having to have people help them and maybe some of their most private activities of daily living. So it's tough for them. We can even see biochemical changes, of course, in the body, and they may show negative changes in personality and attitude. And we've actually seen people, and I've heard of a lot more, that once you relax the tone and spasticity, you can see a difference in their personality. Michelle Miller's an OT from Louisville. I met her father at, he's an attorney at some kind of meet and greet. And she has a very successful children's clinic in another state. And he brought her down to meet me when she was home in Louisville one time. And she started using our products in her clinic. And she called me one day and she said, I just want you to know that we love the little RMI TLSO. And I use it as a preventative of scoliosis. So if you think about it, all the bones in the spine are connected to the ribs, right? And they all have spinal nerves that are connected to all those bones in the spine. So when the nerves are contracting, they very easily pull those bones of the spine offline because they're just bones stacked on top of each other. When they do that, then you end up with curvatures of the spine, very commonly called scoliosis. So if you can relax that tone and keep the bones in the spine aligned, then we have a shot at preventing deformity. They also had a little girl that she had tried, I think it was 5 splints, or this was, our little hyperhand was the 5th one she had tried. And what amazed them is they put it on her, and 20 minutes later her hand relaxed, and they removed the splint, and her hand remained relaxed, which is what we want. With an MS patient, you might relax their tone, but a door slams 3 blocks away and kicks in their tone. But like with a stroke and some things, once you relax, it should stay relaxed until it kicks in again. Or maybe you sleep and wake up the next morning, and that's all individual. But it shows that we're not just shoving on something. We're working with the central nervous system to help it to reach that joint or body part to reach relaxation. I just thought this might be interesting. We had a set of little girl conjoined twins in Louisville a couple of years ago. And the orthotist had done a beautiful, cute little rigid TLSO with the headpiece. And you can see the little girls were joined at the sternum. And this little girl her head had moved sideways to try to stay out of the way of her sister's head. So she had gotten some curvature there. And it's really interesting if you can see on one of the slides, there's a red circle. That's where her feeding tube was. So with these babies, sometimes their organs and things can be a little bit turned around. But she was beautiful. And they said when they put the rigid splint on her, she would just cry and scream. But I took this in and we put it on her, and she had been fussing and fussing and fussing. And when we put it on her, she relaxed and stopped moving around. So we're real tickled. So I have no idea where they are today, but it was a fun experience. And I was very honored. How do you assess a patient for the best results? You want to make sure their environment is relaxed. Now, if they're in the therapy gym, it's a little challenging, but if they're in their room, you can turn the TV off. Remember to tell them you'll turn it back on. Try to lower the lights so it's not so awfully bright, but whatever noise there is, try to keep it at a minimum. Sometimes I can be like overstimulated, so I know if they have nervous issues, then they certainly can. We're in a hurry, but if we can kind of appear to be calm and taking our time. You want to provide for privacy, protect their dignity. It's really cool if you can determine the body position that does the best job of relaxing the tongue. A lot of times it's good 90-degree pelvic tilt. But whatever, find their position that helps relax their tongue. You're going to make decision-making on the products that are appropriate for each condition. It's not one splint is the best for everybody. And where do you begin? You know, if you've got a tightly closed fist versus, I don't know, your staff can't handle everything. So they really need knee splints too, but the fist is really, you know, the hand is bad. So you might want to start with the hands, start working on that, relax. And that could relax other things in their body too. Again, orthopedics, you're going to work on a hand that has been injured. But a hand from a stroke may also relax the other side hand, which also you sometimes see it affect the whole body. So it's just really pretty interesting. And again, it's a puzzle. Speak directly to the patient, not the other people in the room. They are your focus, and they deserve you. Speak distinctly. You don't have to yell at them. Have you ever yelled at somebody that's deaf and then you realize that they're deaf and you didn't need to yell at them? I did that. No, I still feel foolish. Ask permission to touch their body. Do not use the word hurt. If they hear hurt, that's all they hear, and they think that you're going to hurt them. Just say, this is going to feel good. And if restorative hurts, we're doing it wrong. Here's a young man that was 22 when he was moved to a long-term care facility, and I want you to look at his wrists. You can see how much curvature he had in his spine because this isn't that uncommon. I took his gown and put it under his rib cage. You can see where it protrudes out. What you can see on top of his left leg that's kind of a little bit past 90-degree angle at the knee, underneath, that's his right leg. So then, again, you can see all the splints and how much he relaxed, and this was in less than 30 minutes. This is a little lady. Don't predetermine what your patient needs or that they're going to be a certain, just because of their age. My mom didn't retire from public work until she was 85 and was a farm gal anyway, so she's amazing. But this a fitter told me they were called to this lady's house, and it was in the winter, and she was 80-some, and it was for a hand splint. So she assumed she was going to get there, and the lady would probably be in a wheelchair or in bed. Well, she got there, and there's a sweet little lady out trying to shovel snow off her driveway. And she held her hand up, and she said, I just need my fingers lined up so I can keep working. So she helped design, this was a custom splint, but it held her ulnar drift deformity in normal alignment and made her much more comfortable. This Miss Dorothy, I use this, it's a really old slide, but she had TIAs, and I want you to look at her in the left-hand corner. See her index fingers? That is from TIAs that whip those underneath her palms. So they, with a little gentle massage and these hand splints, she just did really good. This you can look at more later, but think about not just the spine. Why would you treat spine? Well, this goes into where those spinal nerves feed, and it's like electricity in your home. If the electricity isn't working, nothing works. If these spinal nerves are not doing a good job, then it's going to very likely affect these internal organs. And on the right, it's possible symptoms that might occur. So it's a really good slide. These are common, very common. I want you to look at the first one, scoliosis. See how the left pelvis is up, the iliac crest is up. So we don't know which came first, the hip being off, the iliac crest, or the curvature, but your body compensates. So what you would want to do here ideally is a TLSO to help correct that curvature, plus I would probably, if they stand, especially if they walk, put a little weight on that left ankle to also help pull that down. I'm sure you've had people say, well, we need a lift on this shoe because the leg is shorter. Well, if that leg wasn't shorter for 60, 70 years, then I don't know that it is now. It could be that we just need to redo the bone structure. Kyphosis, this is one that we see so much, and just a lot is gravity, and we do a really good job with that. And lordosis is not as common, but we can certainly work with that. And this just shows the opening, the foramen, that has to be patent for spinal nerves and blood to come through. And on the right, you can see normal disc, degenerative, bulging, herniated, thinning, and then there's even some bone spurs. So you can see how that's going to affect the spinal nerves and the blood flow that's supposed to be going through there. And this just shows the one on the right. I love that because it shows how angry and painful. When these little people say, I can't sit up any longer, then we need to help them because they're probably in a lot of pain. Why would a facility treat a contracture? OBRA of 1987, that was a federal law, still in effect. You young people may not realize it, but a lot of us lived through it, and it turned long-term care upside down. Cost of care, many times this is the reason a person of any age requires institutionalization. Dignity of the patient. Facilities liability. Somebody's going to come along and say, well, you should have, my mom fell and you should have treated her contractures or it caused wounds or something. So we want to show, and this is what OBRA said, you have to show everything to prove that you prevented them from getting lost range of motion or cured what was there, and then an increase in revenue. We're running short on time, so you can come back and read these, but it's harder for you all to lift patients when they have gross deformities. So, and it's certainly harder on them. It helps decrease hospital readmission because these contractures can lead to real health issues, including urinary tract infections. This is a recent patient that a fitter did. And they were hesitant to do anything to her feet, but what she did was really remold. These are footies. She could have also used flex boots, but she chose these. And we're not going to do miraculous things right now, but we're going to start bringing her back. We're going to protect all areas of her feet, and these can be remolded to continually bring her back toward normal. And I might say, so many times we see patients like this that we actually contribute to their problems. We've put something under, or they've slid down in the bed and they're pushing on covers and it pushes their feet up. And before you know it, their feet are in this kind of shape. We may put their heels up on pillows to prevent the heels from getting to cubes, but we didn't notice that we were hyperextending their knees, and that probably hurt so bad. But then they've got really stuck straight out knees. So try to always consider everything that's around, everything that's in their bed or their chair, and the first thing we always want to do is do not harm. Here's your OBRA. I want you to keep this and read it because they will come back on state survey and get that for you. These are just other things that you can go through. You can read about these. They're pretty self-explanatory. Here's our hip. This is a lady who family wanted to keep her at home, and she bloomed like a flower. I've had therapists tell me that before. See how she just bloomed, and at 29 minutes, she opened her mouth, or she opened her eyes, and she reached out her hand, and that was her smile. And the family was able to keep her at home then until she died. So I'm going to turn this over to Megan. I think we have some more exciting things. If anybody wants to ask questions.
Thank you so much. We've had so many people come into the comments and just thank you enormously for sharing your expertise and the images, and just so all of our attendees know, because there have been some questions about that as well, everybody will receive a copy of this slide deck in our email tomorrow. So whichever email address you registered with today, you will receive an email tomorrow to fill out that survey for credit, as well as to receive the slide deck. So for now, let's hop into some questions that came in. All right, let's start with this one. Karen, I have a patient who has so many contractures that I'm not even sure where to begin. How do you recommend an approach? Where should I start?
I tend to first look at spine, but you want to look at what is the most immediate danger to their safety. So if it is that hand that is totally closed and you're getting sloughing and odor, and I mean, people can even lose fingers and thumbs from that. It could be hygiene. Can you absolutely not do hygiene to their peri area? But a lot of times, if you can improve their posture, their spinal posture, even if, get them up, try to get them up in a chair if at all possible. And that's usually a good place to start, and that can affect the tone and the positioning of the rest of the body.
Excellent. The next one I'd like to get to is, can we reuse these splints on different patients, or is it one splint per patient? These
are, by strict FDA rules, single patient use only. You can, if they wear out on that patient, you can order a new padding or whatever, but do not share them patient to patient, because you don't want the liability of doing something like that.
Excellent. Let me take a look here. What is the wearing schedule for the splints?
It's individual, but we always say, as a manufacturer, we say the same thing every time, and that is start out with 30 minutes. Take it off, check the skin. If you're the treating clinician and you feel totally comfortable putting it back on and leaving it a little longer, then that's your determination. But we like to gradually build up a wearing schedule. And I use the analogy as if you and I go to the gym and start new exercise and we're feeling pretty good and we do just maybe a little more than we should, the next day our muscle is going to be sore and we're not going to want to wear it. We're not going to want to do that exercise again for a while. So we want this to be successful. It's not get it done in 2 days. It's over the long haul.
That makes sense. So this next one, this particular attendee is pretty impressed with the results that you've been able to share. Do you think that these results would be typical or would be difficult to achieve with anyone with an intellectual disability who might struggle with even having staff work on range of motion?
You know, we do have some patients that you can't even touch them. It sets them off, and these are typically in our more mental challenged population. But because they are comfortable, we tend to have really good success. And I've had patients that I've recommended just put it on without any stretch at all. Just get their skin and muscle used to having something on. And then you can kind of sneak up on them and gradually start to put a little stretch on it.
Excellent. So here's a unique question. Do you have a good definition of contracture? This particular attendee feels that most definitions come across as vague. And how are they sure when to document as a contracture versus a limited ROM?
There's a lot of controversy. If you, let's say you Google contracture, you're going to have old therapy definitions of it is a permanent fixed position shortening. And we know that's not true. We know it's not permanent. Now, some of them can be, but there are a lot of caveats to that. So I use any limited range of motion, whether it's shortened tissue, whether it's tone and spasticity, as limited range of decrease in range of motion. If they can't fully extend their joint or body part, then it has limited range of motion. So it's almost like we need to make the word contracture kind of go away, but just know that it is absolutely not necessarily a fixed. And we especially need to make sure the government does not think that it is a fixed, permanent shortening. Now, if you've got a orthopedic condition, you know, that it was a really horrible injury, it may have shortened to that, you know, everything's, and it may be permanent, certainly. But the word contracture has been thrown around just too lightly over the years, and I prefer to say range of motion, and then you can specify the cause.
Excellent. So that brought forward a bunch more questions. We're going to get to maybe 4 or 5 more questions just for all of our attendees. Please keep sending those questions in. Anything that we do not have a chance to get to live here, I will make sure that Karen gets a chance to look at these questions, and so that we can get some answers out there for you. So moving forward with just a few more questions, what is the best time to begin splint trials with someone who has pretty severe spasticity?
As soon as you can. You know, so much of this spasticity with some of our patients, like strokes and brain injuries, starts the 3rd day, by the 3rd day, so they're still in the ICU. So if we wait until they get through that and maybe into rehab, or even through rehab, because we want the insurance to pay for it, then their deformity is so bad, you may never be able to get them back where they should be. In my ideal world again, and someday I'm going to change the world, I've tried, but we start as soon as that tone starts. You measure it and you fit the flex technology splint and go for preventing. Now, if you're doing 2 patients or 2 patient groups and you want to let one group go in a similar that you fit with the devices, that is a true scientific project. It breaks my heart because we know what we can do for all of them. But just the main thing is, as soon as they start to develop tone, treat it.
Good to know. So this next one, how does someone know if a splint is made out of a moldable material?
The instructions should say, look on the manufacturer's website. Everything we make is either of Kydex that you heat mold it, or it would be, we have the Bendy's line that is foam over aluminum, and you mold it by hand.
Okay, so how about, do you see good results with whole system approach with the addition of spasticity meds, like an oral? Ooh, that is that's a word I'm very unfamiliar with. A pump with splinting.
Yes, baclofen pump. Absolutely. Some of these patients' tone is going to be so overwhelming that a very good balance between using the antispasmodic drug and the flex technology splints is just a winner. And there's a slide on when they get the PowerPoint presentation. There's one in there of an 18-year-old young cerebral palsy gentleman, a gentleman with cerebral palsy, and it shows the use of baclofen on his hand, but he had Botox. So Botox, baclofen, there are other drugs, but yes, it's a very good, you need all the tools in your toolbox. You know, you can't just pick one here and one there and say they'll do everything. You look at the whole toolbox and see what you need to use.
Excellent. So the last question we're going to get to live here is, what would you do with a patient that intentionally takes off the splint but is known to have cognitive deficits like a dementia?
Yeah, that's always a challenge. And if you go back in the PowerPoint, there's one that shows a lady that her hand was actually up in her trachea, and but she was notorious for pulling off splints. So, and you can never restrain a patient, but you can be creative. So if they need splints in both hands and both elbows need splinting, the elbows will help kind of hold their hands out, but you can, if you document it really good and address it in your care plan and it's not used as a restraint, you can do like a mesh glove over a hand splint, but usually you have to do both hands. Just don't ever tie anybody down, but just, you can be creative. But if it's comfortable and you kind of sneak up on them, sometimes you can, robbery works good too.
Oh, wonderful. So thank you all to our attendees for those great questions. And Karen, thank you so much for your expertise and your time. As a reminder, by attending today's webinar, you are eligible to receive a complimentary administrator CEU approved through the NAB. You are also available, we also have available 1 nursing contact hour, 1 PT contact hour, and 1 OT contact hour as well. In order to receive that final certificate and your contact hour credit, you must fill out our follow-up survey that will be emailed to you tomorrow. You will have 1 week to complete that survey, and then you will receive your certificate of completion and credit within about 2 weeks' time. Administrators will need to log in to the NAB website to receive your certificate directly. It is important to note that when this particular event ends, WebEx will prompt a technology survey on your screen. This is not our CEU survey. Our survey will be sent directly to the email address that you used upon registration today, and it will include our presentation slides. So now, for anybody interested in learning how Direct Supply can help you navigate these new technologies and products, please help me welcome our dedicated Senior Product Consultant, Kelly Sullivan.
Hello, I'm Kelly Sullivan, Senior Product Consultant here at Direct Supply. Today I'm going to be discussing with you and showing you some products as it pertains to contracture management, the topic at hand that you just learned about from our friend Karen Bonn. So here we have the first product. It is a brace called the Vertebreeze TLSO. It is a great product that's very comfortable and easy to use and addresses postural issues as well as spinal curvature. Whether that be something you're dealing with in terms of muscle tone, or whether it be structural deformities that you're faced with, this is a really great product to look to as a solution. So let's talk about what this is all made of. The front piece here, that torso piece, is very comfortable, soft material that Velcros together. Inside is a flexible aluminum to help accommodate the girth of the individual. Along the back, we have a more rigid aluminum stay in the back there that's going to help support the back and give them that support needed for good posture. The arms here, the arm straps, are great as well. They're, again, made of that very soft material, but also have some padding built in here to help with abduction of the shoulders. So we're going to go through how you might attach this to a resident, and the first thing is that you'll want them in a supine position, fully dressed. We would have them lying on top of the brace itself, and then we would proceed to close that torso strap here with the Velcro, and then we would use the hook and loop straps that you see here to adjust and tug to make sure that it fits that individual nicely. What's great about this is that tomorrow when you go back to using this product, it's already then sized and fitted to the individual. You don't have to go ahead and redo all of the strapping again because you've already done that work today. Then I would sit them upright in the bed, and I would then attach the arms, and those are attached through Velcro. And what we do is scoop this right under the arm and then over the shoulder and then attach along the back with that Velcro. And then that is going to be fitted specific to that individual. That's what's nice about this. We can kind of customize that strap and the length of it based on the placement along the back side there. This product is great in the sense that you're going to have a lot of opportunity in sizes. So they have a range of sizes all the way from a toddler size to a bariatric need. So you have a lot of flexibility in terms of who can use this type of bracing. And the other thing that I want to point out is that it has the ability to really open up the chest and get that person into a more correct posture. So once you sit them upright and you help them to a standing position, they're going to probably take a gulp of air because they're going to have a much better open air pathway because of that upright position that they now find themselves in, rather than that slumped position they were in prior to the brace. We know that oxygen is essential for healthy cells, including brain cells. So having proper alignment and posture is essential for those airways to get that oxygen to where it needs to be in the body. So this is a great product to consider. There are a few other attachments you can consider as well. I mentioned that the back has that rigid aluminum and the front torso piece has more of a flexible aluminum built in. Here I'm going to show you, you can order lateral stays that are a little bit more rigid if necessary for that individual that you're treating. Or there is also a front plate that can be inserted in the torso section if, again, it calls for it based on the condition you're trying to treat. Next, I'm going to show you a couple cervical attachments that are really wonderful when we're talking about someone who might have some movement laterally in their head or maybe forward to back. How do we address those issues? Well, we've got a couple attachments that can do just the trick. And so this one here is the cervical extension. It's a great piece because this vertical vertebrae stay can actually be heated up with a heat gun, and then we can mold it to kind of curve to the back of the person so we can accommodate a person who's kyphotic. So then we would place that right along the back here in this nice little pocket, and it stays nice and secure along the back side there. And we adjust the strap in the front. This is a nice soft material once again that's Velcro attached. We would then adjust that to fit the circumference of their head and that halo piece up on the top here. The halo piece, the sizing, if you're looking at what sizes are available, what they consider a small would be anything under 22 inches circumference, and then anything over 22 inches circumference would be considered a large. So keep that in mind when you're looking at these attachments. The other one I want to show you is the Safe Serve. And this one is going to be really more so addressing that lateral movement in the head. So really cupping the side of the head and really supporting that lateral movement. The one I have here is a left. So when you're ordering the Safe Serve, you want to make sure that you're identifying if it's a left or right side that you're addressing. Same exact stay that we have here that is also moldable. And when I say moldable, we can also remold it once they might have some correcture in their posture, or maybe they don't need as much of an aggressive bend to it. You can always remold it to shape it to give it more of a straight line as they progressively move through their therapy. So here we have, you can see a built-up side to really support and cup that side of the face, and then again, that strap, that piece in the front to keep their head upright so that they can see their world, right? And again, keep their head upright to help with that airflow. So these pieces are really great especially when you're faced with severe postural issues and/or someone that potentially has some muscle tone issues that you're trying to work through. All right, so I'm going to move these off the table here. And next we're going to look at a hand and wrist brace. And this is going to be a great product for those hand and wrist contractures that we all know and see in long-term care. It's highly prevalent in our world. This has some unique pieces to it that I wanted to talk through today that I really like. First of all, it's extremely easy to do. Once again, the name of the game is easy, right? We got to make sure that we can get these on and off relatively quickly and easily without it being too complicated, because let's be honest, they won't be used if it's too complex to use. So this particular product, the Bendies, is a great hand splint that you can order in small, medium, and large. You would identify whether it's a left or right hand. From there, we have a couple different properties we'll talk through here. Just going to take the straps off. As I take the straps off, you'll notice I'm kind of bending that Velcro down so that I'm protecting the Velcro, and we don't wear that out over time because we want that to secure for the lifetime of the product. So here we have your plate. And the technology that is so unique about this is that it's foam over aluminum. So you don't need a hot gun to manipulate the surface to really bend and move it to fit the hand and that contracture. You can easily bend the surface itself. So if I have, let's say, someone with finger drop, I can drop those fingers and I can support those fingers. If I have someone whose hand is and wrist is contracted downward, I can move it like so. So lots of opportunity there to kind of bend and move that plate. Also has some finger separators here, which are pretty common on these types of braces. I do like this one. Velcro's off though, so if I do have some deviation, I can move those fingers and tug away to kind of recorrect the positioning to a more better alignment on the surface here. So I'll put my hands in there. Here we have where you attach the thumb. And one thing you'll notice is that there is color coding straps along throughout this entire brace. So the back, you'll see once we get to those straps and start attaching them, you'll see where those attach. But you can even just see from a glance here, we have different colors that help you identify exactly where to put those straps, making it much easier to attach. So I'll throw my hand back in here. I'm going to wrap that thumb up nice and gentle because depending on who you're dealing with and what's going on with the thumb, we want to make sure we're taking it nice and slow and walking the resident through it and talking them through the attachment to make sure that they are comfortable. This first piece is going to go right over the top of the hand. And again, pulling slightly and gently so that we're making sure it's comfortable for the resident. The next piece I'm going to show is either going to go over the knuckles or over the tops of the fingers. And that's really going to be dependent on, are the fingers lifted? Are the knuckles lifted? Where that placement is going to be on the hand. So we take that, we unwrap, and then we slowly kind of tug underneath that thumb, and then I'm going to put it over the tops of my knuckles here to keep my fingers down and in place there. And then we have another piece here, that middle section, and this is really more or less an anchor. It's going to keep that wrist down so I don't move. And again, you can see that red to red attachment there. And then last but not least, we have a forearm anchor as well. So I have this nice, comfortable resting hand now. If I needed to, I would have been bent to fit my hand. Ultimately, we want to get back into that C function, and this allows for that progressive movement. I think that this is a really perfect product to consider if you're looking at a fresh stroke or a mild to moderate hand-wrist contracture. It really works well for those patients. And I think too, it's, like I said, pretty easy to use and straightforward in terms of how and where to adjust it. And I mentioned the color coding, but this is not like end all. You can move those straps where you need to move them, providing what you're dealing with at hand. So if you need to move them to a different place on the brace, by all means do so. This is just to give you some general guidance. In terms of laundering, we do suggest that you pull the fabric off of the aluminum stay in the middle, and that you wash the aluminum stay. You use like a gentle detergent with the outside of the brace, the fabric piece, and then you air dry. We don't really suggest that you put it in the laundry and use it on high heat, because you'll have a very little brace covering at the end of that. So just if you have any questions whatsoever, we're here to help you out. We hope that today, between what Karen presented and also the products that you were shown here, will help you kind of think through maybe a patient you're working with currently and look to maybe this as a product solution that will really help the resident be comfortable, but also help with that as a treatment piece to their recovery. If you have any questions, reach out to your account manager for pricing, and/or they can connect with me and we can talk through other options and/or the options you've seen today. Appreciate your time. Thank you so much.
An extra big thank you to Karen for her time and expertise today. Really, we'd like to share our thanks with everyone who took the time to join us. If you have any questions about the items discussed in Kelly's presentation, you can feel free to email us at webinars@directsupply.com. You can also use that email address if you have any questions. Thank you so much for joining us. Have a great rest of your day.